first pill that I tried was Yaz, and I felt like it was making me feel much worse than I'd ever felt before.
When I was first put on the pill, I wasn't advised to skip the sugar pills and take it continuously.
But I always had awful side effects, migraines or really bad nausea.
If it managed the bleeding, then my mood would be terrible, like I would have depression or really bad PMS, and that just turned into trying lots of different pills.
I tried Zoladex, which was horrible. Before I had my hysterectomy, I did Cinerol,
Microgynon,
Levelin,
Ralavera,
Lupron, Monofem.
I've tried Lyrica.
I think it was 6 months of Zoladex as a 15-year-old, which was quite intensive.
But I've noticed that even if I take the pill later in the afternoon than I'm supposed to, I get the excruciating pain again.
In the last 2 years, I've been on a continuous oral contraceptive, high dose, which I've taken every day religiously, and by stopping my periods has meant that I've stayed out of hospital.
I've had the Mirena, which was a disaster. I had my period every 2 weeks, for 2 weeks.
This is my second Mirena. So we decided to try it again only because of the cost, I guess.
I'm on my second Mirena.
I found out that it actually punctured through and was not in the in the uterus anymore. So I had to go get that taken out as well.
The Mirena for me meant heavy bleeding, constant heavy bleeding, erratic mood swings, paranoia, horrible.
And he gave me progesterone, and for the first time in my life I've had some relief.
My topic is hormonal contraception and endo, and my aim is to perhaps bust some of the myths around that certainly I think exists out there in the community around hormonal contraception particularly. So I have worked with drug companies, both in an educational and consultancy capacity, so you need to know that full up. But I wanted to look first off at some myths, and these are 10 of the biggies. The pill makes your body think it's pregnant. It doesn't. Okay, the levels of hormone that you get on something like the oral contraceptive pill are significantly less than you see during pregnancy. Hormonal contraception makes you gain weight. Well, it's got no calories in it, but I do agree, for some people, it can certainly stimulate the appetite. So we need to manage that, because often that's one method will do that, other methods won't. It's dangerous to run packets of the pill together, and this is my top message today. I still see that on internet forums, that you shouldn't do this, it's dangerous. And I'm going to challenge that, because particularly for women with endo, it's really important they understand what they're doing. Every time that you bleed, all the little bits of endo that are in the peritoneum and around scattered will also bleed as well, increasing the risk of scarring and problems. So it's really important that we minimise the amount of bleeding that women with endo get. Regular menstrual bleeding keeps you healthy. Well, this is a sort of Greek idea that there's a degree of catharsis involved in menstruation. There is absolutely no real reason to menstruate, in fact, unless you're trying to get pregnant. Being on the pill for a long time makes it harder to get pregnant. I'm going to show you a study that actually suggests that it's easier once you've been on the pill, and that's probably because it protects to some extent against things like pelvic inflammatory disease and endo. It's a good idea to take breaks from the pill every now and again. Well, no, it isn't. In fact, when you take a break from something like the oral contraceptive pill, you go back to your initial risks around clots in the legs and the lung. So unless there's a really good reason, and I agree, if you're sick of taking it, that's a good reason, but there are no medical reasons to take breaks. Emergency contraception and IUDs work by causing an abortion. No, they don't. They stop you getting pregnant in the first place. Women who haven't had babies can't use an IUD. They can, and they should, and if they want to, and many, many women do. IUDs cause pelvic infections and infertility. That's a really old belief that's no longer held. So we don't need to worry about that one. And the pill increases the risk of cancer. Now that's number 10 because it's a half-truth. It does slightly increase your risk of breast cancer and cervical cancer. It greatly decreases your risk of ovarian cancer and endometrial cancer. So, we need to factor that into our discussion and our decision-making. Okay, I wanted to go through the contraceptive menu before we get started so that you knew what was on the agenda. So the pill and the ring. We can get pills for $6 a month, so they're cheap. The ring costs you about $30 to $35 a month. When we're talking contraception and we're talking pregnancy rates, we need to distinguish between what you see, in a trial and what you see in real life, real people getting real drunk on real Saturday nights. So the perfect failure rate with a pill is about 0.3%, but the typical failure rate's more like 8%. And that's because there's a lot of human commitment in there, having to take that every single day. There are nearly 30 brands available in Australia, but some of them are identical. So I sometimes see people who say, I've tried lots of pills, and when I go through them, 3 or 4 of them are the same pill, really. Maybe in slightly different dosages, but often the same pill. Safety, well, there are rare but serious risks of clots and stroke. But if we have a look at a large English study, looking again at real women in a general practice setting taking the pill for years, and they had thousands of them, they actually found that there was an overall long-term reduction in death among pill users by about 12%. And certainly, as I said before, prolonged use of the pill actually increases your chances of falling pregnancy, rather than it is widely believed decreases them. The other nice thing about the pill is we're talking about suppression and cycle manipulation. It's the one thing that allows you to do that. Some of our speakers in the video were talking about the fact progestogens are great, but you can pretty much say goodbye to regular cycles. Okay? You cannot control cycles if you're on a progestogen-only method of contraception. So we do have progestogen-only pills for those people who can't or don't want to take estrogen. They're exactly as effective as an ordinary pill, but the human commitment becomes even more critical because you've only got 3 hours to remember to take them or your cover goes out the window. So they're pretty great for card-carrying obsessive compulsives, but I love the way they always provide them to, women who were postpartum, And I remember being postpartum, I didn't know what day it was, let alone what time it was. So, it's hard, and they're not a great choice for women with endometriosis either because of that irregular and unpredictable pattern of bleeding. And as I said, every time you bleed vaginally, you are also bleeding for the little pockets of endometriosis that you may not even know you have. I was asked to speak about Visana, and it's here because although it probably is contraceptive, there is no contraceptive data. The company that markets it cannot market it as a contraceptive because they haven't done the prerequisite work to get that done. But, it almost certainly is contraceptive. Whether you have to take it within that 3 hours, we don't know. The contraceptive injection at the bottom is Depo-Provera, Depo-Ralavera. Perfect failure rate 0.2, typical failure rate more like 6. It's given as an injection every 12 weeks. It has a hugely profound effect on cycles. Most women have no bleeding by 12 months of using it, but it takes a long time to reverse. It can take 10 or 11 months before your periods come back when you stop it. So it's not a great method for somebody who might be planning a baby in the next 18 months, obviously. Implanon NXT. Okay, up to 3 years effective contraception, very effective. Failure rate of 1 in 1,000. That's better than you get with a vasectomy. Okay, so pretty good. Very rapid return to fertility once you remove it. So that's great for somebody who does want to get pregnant. But again, unpredictable bleeding. And I explain this to people with my hand. About 20% of people get no bleeding. About 20% of people get the cycle from hell. Okay, and everybody else gets something in between. And you don't know till you've given it a go exactly where you're going to fit on that spectrum. We've talked a bit about Mirena, or a number of the other speakers have already. It gives you up to 5 years effective contraception, failure rates 2 in 1,000, neither here nor there really. Rapid return to fertility once it's removed. By 12 months, 80% of women have no bleeding or an occasional light bleed. Both of these are PBS listed, so they cost $38. It's actually $80 now, and both have failure rates of less than 2 in 1,000. So it's really good contraception, and we'll talk about their impact on endometriosis in a minute. Okay, there are non-hormonal methods around. I mean, we all know about condoms. They're the best method of protecting you against STIs. They have no impact on endo. This is the only diaphragm now available in Australia. It's called a Kea. One size fits all, so at least you don't have to go through a fitting procedure, which is great. Not as effective as other things that we could be, suggesting, but anyway, it's there. This is a fertility monitor. It's sort of high-tech natural family planning, and you can bring those across from England on the web. And this is a copper IUD, and it's non-hormonal. That has real appeal for some women, but it actually makes symptoms of endometriosis worse. So it's probably not something that should be considered in this particular context. Now, the reason I sort of started with contraception but want to segue on is that a US survey indicated that 14% of pill users are not using it for contraception, they're using it for something else. And 58% are using it for both contraception and something else. 31% for pain, 28% for menstrual regulation, 14% for acne, and 4% for women who've actually been diagnosed with endometriosis and are using it to control their symptoms. So I like stories, okay, and this is Dayiyu. She's 14, she sees a doctor with her mum. She's not yet sexually active, though we might want to get mum out of the room to sort of check that out, really. But her first period was age 12. Her periods were very irregular for the first 12 months, but now they're coming roughly monthly. But her bleeding can be really heavy, and she describes as having clotting. And she needs a change of pad 1 to 2 hourly on her very heavy days. She also gets quite severe menstrual cramping on day 1 to 3 of a period. Now, just to draw a line in the sand, heavy menstrual bleeding and this sort of pain is quite common at both ends of the reproductive spectrum. So in very young women and very old women, you often get very heavy periods. Clots are just an indication of heavy bleeding. So blood from the uterus will clot just like any other blood, but once it actually comes through the cervix, there are little enzymes that munch it up and chew it up and it comes out as a liquid. If the bleeding is really heavy, those enzymes don't have a chance. So it just indicates that bleeding is somewhat heavy. And it's one of the questions doctors ask to actually work that out. The reason I bring it up is that it might just be that Dayiyu is in the first couple of years of her reproductive life, but it also could mean that we're seeing the first signs of endometriosis. And I do wish that doctors out there in general practice land would at least think about this as a possibility, because we know it can be up to 10 years between the onset of the first symptoms and the definitive diagnosis of endometriosis. So often somebody like Dayiyu will be sent away saying, oh, it'll probably settle down. Okay, well, maybe it won't. And certainly it's impacting on her life right now. There's no doubt, I think, that for those of us who do know a little bit about endometriosis, the suspicion occurs well before the clear diagnosis. And you've heard a lot about repeat laparoscopies and that they're not really a great idea. There's certainly a move, at least in the UK, and I suspect and hope here, that to avoid laparoscopic diagnosis in adolescence, unless there's an overwhelming imperative, but to actually raise the issue that it might be endometriosis, and then to look at medical management of that. Now, pain is common and misunderstood. Everybody else's pain is very easy to put up with. If it's yours, it's a different question. Okay, and I do think a lot of women get sort of, put in a box around, oh, it's just period pain. What are you crying about? Okay, but pain is pain, and severe pain is severe pain. And we do know that 79% of women who are later diagnosed with endometriosis report period pain. 69% report pelvic pain outside their periods. And 51% of women diagnosed report pain during intercourse. Now that's going to impact severely, not only on your ability to enjoy intercourse and sexual pleasuring, but on your ability to maintain a relationship if that's what you want to do. Oh, I wanted to say, the other thing is that many of the hormones that I'm talking about are actually really quite good at dealing with period pain. They're not so good at dealing with the other kinds of pain. So there are limitations, and whenever we're dealing with any of this, it has to be a holistic approach. Analgesia, surgery, medical, hand in hand, not a one-size-fits-all approach at all. And I said before, people put pain down, but it's real and it's awful. And we know that the degree of pain that people get correlates with reducing their physical, your excursions, okay? So you cocoon yourself, you stay at home, you don't want to go out. It impairs psychological and social functioning, and it also impacts on things like educational and work opportunities. 15% of young women report pain so severe as to cause them to miss school or work every month. That's really going to be a problem. We know, conversely, that effective treatment of pain leads to improvement in physical and psychological functioning, quality of life, and general health, and that's surely what we're all aiming for. Suzanne, as I said, isn't a contraceptive, but I did want to bring it in here. It's 2 milligrams of a hormone called dienogest. That's the same as the hormone that's in 2 pills that are available, Valette and Clara. It's licensed for the treatment of endometriosis, and that's largely because of the activities of the conference organisers here, and I say well done, because it's really important. But by 3 months, 50% reduction in pain seen in 37% of patients and 75% in another 19. And you continue to get improvements up to 15 months. And at that stage, you're getting about a 43% improvement. And that pain relief is comparable to GnRH agonists with all that they involve in terms of side effects and short-term only possibilities. There's a substantial reduction in endometriosis lesions at 6 months of treatment. It suppresses ovulation at the 2 milligram dose, but as I said, we don't have contraceptive studies. The ovaries, thankfully, are not completely suppressed. So women on Visan still produce their own estrogen. It's reduced, which is what you want to do in endometriosis, but it's sufficient to protect their bones with long-term use, and that's very reassuring. Irregular bleeding is common, but on Visan it does tend to improve the longer you're on it. Combined pills, vaginal ring, they thin the lining of the uterus. They tend to make periods shorter, lighter and less painful, anything from 40 to 80%. Some pills are better than others, and high-dose pills are not always the best. It's actually better to choose your progestogen than increase your estrogen. NuvaRing causes a reduction in those reporting pain from 42% to 26% by 3 months. And in fact, there are some studies that suggest that using the vaginal ring, because it delivers the hormones locally, might be even better than the oral contraceptive pill for low pelvic or rectal pain. And of course, extended cycling might be more effective for both pain and bleeding. For 2,000 years, medical literature described the disease of menstrual retention on the basis that a regular period is natural, healthy and cleansing. But as I said, the only reason for having a period is to get pregnant. And natural, well, I question that. The modern woman has something like 450 to 500 periods, about 4 times more than her Stone Age sisters would ever have experienced. And although, avoiding regular periods is even more important if they're associated with heavy pain and bleeding. Somebody actually asked women how much do they want to bleed? Most of them said never. Okay, so cycles can be any length. Extended cycles have been used since the 1960s for heavy bleeding and endometriosis. We now have 2 extended cycle preparations available in Australia, Yazflex and Seasonique. Studies have shown no difference in safety out to 2 years. You do get a more irregular bleeding pattern, but most women can go at least 3 or 4 months of running them together without bleeding. But I like the idea of what's called menstrually signalled cycling. That's running it out as long as you can, and only if you get 3 days of spotting, take a 4-day break and then resume. This means you get less ongoing light spotting than you do if you keep going with active pills. And the return of fertility is the same as the conventional pill. You usually get your cycle back within 32 days of stopping it. Does it protect against endometriosis? There's probably a large individual variation there. Some studies do show a reduction in size, but for most of the time it's a question of preventing progression. The trouble is, if you're on the pill, that may delay the diagnosis for several years. Diu's 20, studying business at uni, taking the pill since her mid-teens, tricycling it, lighter bleeding but still moderate period pain. She's had a male partner for the last 4 months. Both have recently had negative STI testing and they've been using condoms. Diu wants to know if there's anything that would be a bit more convenient than the pill. So we could look at a hormonal IUD. Low dose of hormone in the Mirena. Almost all women still ovulate, so it's no good for PMS. It's likely that low constant progesterone makes receptors in the endometriosis less sensitive to estrogen. So that's a positive. Safe for women who haven't had a baby, and easy insertion in about 75% of them. And it reduces menstrual bleeding by about 90%, and pain drops from 60 to 30% by 3 years. With a contraceptive injection, there's a 53 to 90% decrease in pain, and most women have no periods by 12 months. The contraceptive implant, 68% decrease in pain, but as I said, irregular bleeding more common. And the copper IUD is really not a great choice. Diu's 28, working in a large accountancy firm, married 3 years, had a hormonal IUD removed 18 months ago in order to try for a baby. No problems for the first few months, but since then, her periods are becoming increasingly problematic and she's still not pregnant. She's referred to a gynaecologist and endometriosis is confirmed grade 2, so not too bad, and she's treated surgically at laparoscopy. Now, about 30 to 50% of women with endometriosis have trouble getting pregnant. Surgical treatment of lower grade endometriosis certainly improves fertility in the 9 to 12 months following treatment, but the improvement's less clear for those with moderate to severe endometriosis. And women can expect improvements in symptoms for up to 5 years after surgery. And the good news is that Dayuyu delivered her baby Jan last week. She plans to breastfeed him as long as she can, and then they'll make a decision about whether or not they'll have another child. And the important thing here is suppression. So if she's got no immediate baby plans, it's important to do something proactive. We could use Fazan. That's an option if she's not requiring contraception, but as I said, it is contraceptive. The pill reduces recurrence rates after surgery in 50% of women. It reduces pain, it reduces bleeding, but it doesn't have such a great effect on non-menstrual pain and pain with intercourse. Mirena, effective for pain and bleeding, possibly less effective with very distant endometriosis. We were talking about diaphragmatic before. Implanon reduces pain and bleeding and is rapidly reversible, so it's an option. Contraceptive injection, great, but if they want another baby, maybe not the top of the list. And this is what a number of our speakers have referred to. Increasing use of combination therapy. Mirena plus Implanon, Mirena plus Fazan, Implanon plus Fazan. Those are all options that people have as well. In fact, we have a whole range of options, and it's a shame that they aren't given to people so that they get the best possible choice. The ideal contraceptive for a woman with endometriosis would be one which, cheap and easy, provides effective contraception, provides symptom relief, rapidly reverses, prevents progression of the endometriosis, has a positive effect on well-being, and fits in with the woman's own personal philosophies and preferences. And unfortunately, like the Holy Grail on the left, it's not existing yet, but we are still trying. Thank you very much.